gentlemen, good evening. I think without further ado, I would like to start this evening, despite the fact with all this traffic condition, the weather condition, we have had still a lot of people and a lot of people are missing. I guess that would be their loss rather than ours. Dr. Jhas, I'm so sorry, but usually we have this auditorium full, and for your purposes, we were hoping that we may have to bring more chairs or something. Maybe the weather has helped.
No, rather it's the seventh game for...
Oh, that too. There are 3 games. Yeah, Leafs and... Well, ladies and gentlemen, I don't think it's going to...
More patients are at the end of this game.
To introduce Dr. Jhas, it's a very simple thing. He has been known as a new kind of a brain surgeon at the hospital. He is a cerebrovascular and endovascular neurosurgeon at the Trillium Health Partners. In pop culture, as that's known, it translates into a simple English words of a brain surgeon. One of the most complex and challenging jobs in the world, as per our hospital. But when you talk to him, he will very modestly say, it's just like any other type of a surgery. But then he also adds, except that the stakes are far too higher than a big poker game. This new kind of a brain surgeon, humble about his incredibly complex work, with a passion for best in the patient care. His origins have been very different. I mean, because I just got this piece of paper from the Trillium Hospital. Origins of a brain surgeon, as it's been saying. How he became a brain surgeon. And his surprising answer was, indirectly through my dad. My dad was an engineer in India who became a mechanic in Canada. And even on my busiest days, now as a surgeon, he still always worked harder than me. When he was a boy, Dr. Jhas, when he was a boy, he would spend hours in his dad's auto shop. His father would let him tinker over engines. Looking back, he recalls, I see that certain skills and the necessary personality to become a brain surgeon were formed in my dad's garage. Different kind of a brain surgeon. Without further ado, ladies and gentlemen, let me invite Dr. Sumit Jhas. Let's give him a big hand.
Okay, good evening, everyone, and thank you all for coming. Obviously, with the multiple games that are going on, appreciate your attendance here. So thank you, Anil, for, yeah.
That microphone is only for that camera. You need the other one.
Really?
The handout.
Okay, so I'll do. No worries. Hello?
Yeah.
So two mics. Okay. Here, go back. So, yeah, thank you, Anil, for the introduction. And I am a neurosurgeon at Trillium. I've been practicing there for about 3 years. And my focus is on kind of everything, but mostly the blood vessels of the brain, so diseases related to the blood vessels. So today I wanted to focus on stroke. So at the end of this, I hope that you guys get a sense of what a stroke is, how to identify that, how to prevent a stroke from happening, and then to learn a little bit about what we've been doing up until now in terms of treatment and the new breakthroughs that are on the horizon. And that a lot of that is just to really empower you to kind of go out, if you do have a loved one or someone who does have a stroke, that you can speak to your physician about the new treatment modalities, because one of the challenges is that people actually don't know about what we're doing nowadays. And so we're actually going out to hospitals to educate physicians about the new treatments that are available. So it's kind of uncommon for a neurosurgeon to be talking about stroke. And in fact, I never really, as Anil put out, I never really started out to become a neurosurgeon. In fact, my plan was to design cars for a living. I wanted to be a mechanical engineer. And so working in my dad's garage, that was the plan. In fact, in high school, I never actually took biology. I was going to university, but my grades weren't so good for engineering, so I was going to do general studies and then transfer into engineering. And so when I got to university, which was in Calgary, I ended up staying, did biology and enjoyed it. And then I ended up moving to Montreal where I did a master's in neurosciences and then kind of enjoyed that and moved on to medicine. And one of the things I liked about neurosurgery and neurosciences is that, you know, everybody has this sense that if you have a neurosurgical problem, it's devastating. The outcomes are going to be bad, right? That people don't do well. And so for me, it was more of an opportunity. And, you know, with innovation, with the new things on the horizon, this was a specialty where you could actually eventually make a difference. Certainly at the time that I got into it, you know, people still had bad outcomes with brain tumors, spinal cord injury, and strokes and things like that. And so getting into it, that was kind of the reason that I got into neurosurgery. And you'll see with stroke and neurointerventional that it's really come to fruition, all of the things that we wanted to do in terms of helping people. So to start off, I wanted to talk about stroke. So what is a stroke? So in simple form, it's basically a brain injury. And the brain injury occurs when a blood vessel is either blocked or the blood vessel actually bursts or ruptures and bleeds out, right? And this causes a loss of oxygen, a loss of blood flow, and it causes those brain cells to die. So why does that matter for the brain? Well, there's three things that I'll tell you that are important to know about the brain that makes it different from any other organ in the body. And the first thing is that brain cells can't recover. And for the most part, I think we all know that. When someone has a spinal cord injury, they don't recover. When someone has a stroke, there's damage that doesn't recover. And there's a whole mechanism for why that happens, but for the most part, brain cells don't recover. Unlike cells, say of the heart or the liver or the bones, which can heal, these cells don't. The other important thing is that brain cells don't store energy. So cells, for example, in the heart, they store energy as a form of carbohydrates. So if you were to transplant a heart, you can take it out of someone's body for 5 hours and then transplant it into somebody else. But the brain uses glucose directly from the blood supply. So immediately when the blood supply stops, it loses its energy. And it starts to die off within minutes of losing that blood supply. And so when it dies, it can't repair itself. So there's a timer associated with brain injury and brain cells. And the last thing is when those brain cells die, they swell. And when they swell, unlike, again, the liver or other organs that can swell, in the brain, the swelling is internal, and it's a closed box. So the pressure increases, and when the pressure increases, it causes more damage. And that's how people die of a stroke. It's the swelling that happens afterwards. It's not usually from the stroke itself. So with that in mind, what is the challenge with stroke is restoring blood flow as quickly as possible so that those cells don't die, and preventing the secondary injury, the swelling that occurs down the road. So who is affected by strokes? So in Canada, and these are the numbers, there's about 750,000 people living with the things associated with stroke. There's about 60,000 strokes that occur per year, and about 13,000 people that die from those strokes. So one thing I'll tell you, and this is what I've kind of learned in my practice, which was different from medical school, is that statistics and numbers really don't reflect the burden of disease in society. And it doesn't really reflect the family impact, right? You know, when you have a stroke, no amount of disability or life insurance is going to cover that loss, right? So I'll tell you a story about a patient I had when my first year in practice. And basically, this was a guy who came to my clinic, and I was seeing a lot of patients that day. And he came in, he was very disheveled, kind of dirty clothes. Most people wear, you know, a shirt and tie kind of thing. And, you know, hair was undone. He had a book in his hand. And so came into the clinic, and, you know, he smelled of alcohol. And sure enough, he was holding a book that actually said Alcoholic Anonymous. And so I thought to myself, oh, here's a guy, you know, I mean, he couldn't have waited, like, you know, clearly is alcoholic. I looked at his MRI before I saw him in the clinic, and I realized that, you know, this guy doesn't have any problems. There's nothing surgical for him. So we're just going to quickly talk about pain and then get him on his way. And so as I'm going through the things, it says, okay, are you working? He says, no. So sure enough, he's on disability, right? Hasn't been working for a year. And so as part of that, I asked, okay, well, you know, have you ever worked? Which I don't really ask, but I ask a lot now. And he said, yes, I was an executive for an accounting firm in downtown Toronto. So that sparked my interest. It's okay, you know, this is the guy that does not look like a high-end executive for an accounting firm. And so when I asked him, okay, well, what happened? Like, why aren't you working anymore? Is it because of the back pain or whatnot? And he said, I came home one day from work and I walked into my daughter's room, his young daughter, and she had passed away, right? And it was devastating for him, right? And his marriage fell apart. He lost his wife. He never recovered, became an alcoholic, and was on disability for that. And so the statistic might say that this, child mortality is X, but you'll never see the real impact that it has on families. And so stroke is one of the things that is very, very detrimental to the community. It is the one of the few diseases that will take someone in the prime of their life and kind of destroy that life. And it won't kill you. Majority of people will survive it, but it will take you away from the life that you knew or the life that you expected. So this is the reason that it becomes a huge burden for society and something that we want to focus on. Now, the first thing about stroke is, who's at risk, right? So the number one risk factor is usually high blood pressure. So in this chart, basically you see those bottom four are non-modifiable risk factors. Those are things that you have that you really can't change. Your age, your sex, your ethnicity, and the family history. But the other stuff is modifiable. And things like high blood pressure, diabetes, smoking, elevated cholesterol, all of these things can reduce your risk of having a stroke. And in fact, there are some diseases that we can treat with medication or stenting or things like that will prevent your risk of having a stroke. So in the Indo-Canadian community, it's a kind of a particularly interesting group in that Indians who have immigrated to Canada with westernized diet and westernized lifestyles have different diseases that are different from what we see anywhere else. So for example, type 2 diabetes, it was always known as a disease for obese people, right? It's an obese person's disease. But in the Indian community, many Indian men have type 2 diabetes. And despite the fact that they're relatively thin and well, and so what we've found is that it's a lot to do with these high carbohydrate diets that were designed for farmers in hot climates that could burn off those calories, and they don't do that here. And the sedentary lifestyle leads to this diabetes. In addition to that, there's high blood pressure. So what we find is that there's not a higher risk of stroke in the Indian community, but if you do have a stroke, you're actually 1.5 times more likely to pass away from that stroke. And if your risk profile is the same, equivalent to a white Canadian, for example, where you have high blood pressure, diabetes, you don't smoke, you're going to have a worse outcome than someone who is a Canadian. And we don't know why that is, but that seems to be one of the issues. Now, we know that Indians have a sedentary lifestyle. They tend to be a little bit more overweight. The culture is not one of exercise, but we don't smoke. And so for whatever reason, we don't do as well, right? And so it's important to let the community know about things that they can do to modify those risks. So a little bit about the science of it, just in terms of the terminology. So a stroke is an all-encompassing term that refers to two broad categories. Ischemic stroke is where there's no blood supply to the brain, so no oxygen, no flow. It's about 90% of strokes. That's the one that we're really interested in. Hemorrhagic stroke is bleeding in the brain. And bleeding in the brain is almost always as a result of an aneurysm or high blood pressure and other things, but we won't focus on that. When you look at ischemic stroke, there's two major categories. Embolic, meaning a clot from somewhere else in the body, usually from the heart. When you have a abnormal paced heart, will form a clot and it goes up into the brain and causes stroke. Or thrombotic, which is a plaque in usually the carotid artery that breaks off and causes the stroke. And so both of those are treatable, and these are the terminologies that we typically will use. So from the American Heart and Stroke Foundation, this is the kind of the pamphlet that they give to everyone for you to identify what a stroke is. So the mnemonic is FAST: facial drooping, arm weakness, speech difficulty, time to call 911. Basically, the gist of this is that if you see a focal deficit, so having weakness in your entire body is not a stroke. Having weakness on the left side and not the right side, very few things can cause that except strokes, tumors, things like that. That's where you really are looking for something that's happening in the brain. So if you see something that's not happening on the other side, and you use that as your control, that's a good reason to call 911. And acute is the term to use, right? Something that happens very quickly, right? It's not something that's slow or progressive. So these are things to look out for, and calling the emergency department is critical because time is everything. So the brain is divided into two hemispheres. The left hemisphere is important for controlling movement on the right side of the body, so everything is crisscrossed. So if you have a stroke on the left side, you're not going to be able to move the right side. You'll have a left facial droop. And for majority of people, even those who are left-handed, speech is on the left side of the brain. So people who have a stroke on the left side have a worse outcome, because even if you can't really move that well, being unable to speak is far more devastating for many people. Things on the right side are creativity. In certain locations, you'll have a disability, but you may not notice it. For example, it takes a significant amount of brain power for you guys right now to think where your car is parked relative to where you are right now, right? That's executive function. It takes a lot of brain to be able to do that. But if you have a stroke in that area, you're not really going to notice the loss of that function. And that's why the right side people do. So I want you to basically, this is a patient case that I'll talk about, and really it's for you guys to kind of visualize somebody that you may know that may have this, right? And so we're going to talk about two stories of patients and different outcomes based on, what happened in their course. So this is a guy, he was 54 years old, again, an accountant. He has two young girls who are teenagers, and he basically went to bed around 11 p.m. His risk factors are he has high blood pressure, diabetes, which is he's medicated for, non-smoker, sedentary lifestyle, right? So kind of your typical average Indo-Canadian person. So he goes to bed at around 11 p.m. His wife and him go to bed together. And in the morning, she typically goes downstairs a little bit early, makes breakfast, and then he comes down about 30 minutes later. So this particular morning, he doesn't come downstairs. She goes upstairs to see him, and he is lying on the floor, unable to speak, unable to move the right side of the body. So right off the bat, you're thinking focal deficit, left side, probably stroke. So she calls 911. They bring him to the emergency department at the hospital. So there, the first thing that a doctor is going to ask you is, when were you last seen normal, right? When was the last time that you didn't have a problem? And this particular problem is really bad because the last time that anybody saw him normal was 11 p.m. It's 7 a.m. now, right? So that's 8 hours ago that he may have had a stroke. But the reality is he probably had his stroke at 6 a.m. when he woke up, right? When he was trying to get out of bed, that's probably when he had it. But for medical purposes, it's 8 hours. So that means that he is not going to get treatment, right? And the treatment that we typically give is a medication called TPA, which is a clot-busting medication. It dissolves clots. It works really well, but you can only give it in the first 4.5 hours after a stroke. So when someone is not a candidate for whatever reason, there's no treatment for them, right? Basically, you cross your fingers and hope the blood flow gets restored, or that there's not a lot of swelling, or it goes from there. So a little bit about TPA. This has really been the mainstay of treatment for most patients. So this is not to be complicated, but basically this is a graph showing that as you get longer and longer away from your stroke, the proportion of the brain that's actually dead, what we call infarcted brain, increases, and the proportion of the brain that has decreased blood flow but is still alive, called hypoperfused brain, reduces, right? And so the more you have a dead brain, the more likely you are to have a hemorrhage or a bleed when we give you a clot-busting medication like TPA. So the literature has said 4.5 hours is where that balance is. Anything beyond 4.5 hours, there's more risk to bleeding than there is benefit to it. But that translates into only about 10% of patients who are candidates for TPA. That leaves 90% of strokes. These patients don't get any treatment whatsoever. So the worst case scenario is these wake-up strokes, right? These are people who probably should get TPA, but medical legally we can't give it because last seen normal was 11 a.m. So this guy didn't get any medication. And this, basically, if you see the dark area on the left side there, your right side, I guess, that's a stroke. That's an area of dead brain. Now that proportion is a significant area of brain that's died. That area includes the area that will control the right side of his body, the area that can control speech. So what we worry about is this thing is going to swell, right? And it's going to swell over the next 3 days. So the next decision in a 54-year-old man is to decide whether he wants to live or not, right? And this is a conversation we have with families all the time, because in neurosurgery, death is the second worst outcome, right? So to be left, vegetative or disabled, to be in a complex care facility, most people consider that worse than dying. They would rather die quickly and be done with it, be remembered as someone who, was a part of the family rather than a burden to the family, right? And so when, especially on the left side, again, unable to speak. So the only option here is to actually just remove the skull and allow the brain to swell out rather than in. And this is a life-saving operation, and we used to do it very often. When I was a resident, it's something we do once a week. And the outcomes were pretty good. People survive. They will not die when I do this operation, but they will survive with a disability. And so a lot of people say no, they don't want that, and they'll pass away. And others say they do want it. And so, unfortunately, all these nursing homes are full of patients who have survived a stroke in this regard. So I don't want to gross you out if you guys are eating, but this is a picture of an operation that we used to do a lot. Brace yourself. So this is the left side of his brain, and we've removed the skull completely to allow that brain to swell. And then we replace the skin, and we put the bone into a bone bank to allow, and then at a later date, we put the bone back in after the swelling has gone down, usually in about 3 months after an operation like this. So unfortunately, this man did not do well, and he survived, but he ended up in a nursing home. He eventually was able to walk with a walker, but his speech never really recovered that well. And think about that when we talk about the impact that has to a family, right? The 2 daughters have lost their father, right? His spouse has lost somebody they're going to grow old with, right? And the income is also gone, right? No amount of disability or life insurance is going to replace that. So the entire family is devastated by this, right? So that one number statistic doesn't really reflect the burden of disease. So this slide is basically to demonstrate what medical management can do and what we expect when somebody comes in with a stroke. So as I said, only about 4 to 10% of patients get TPA. And so in the vast majority that don't, 50%, so you have 50-50 chance you'll be left with a severe disability, right? And that's if you're lucky enough to survive. 20% will actually pass away from the swelling or choose to pass away. But 30% do have a good outcome, and that's either because they arrive in that 4.5-hour window, or it's because somehow the blood supply in some people is really good, despite the fact that they can't have blood flow. They get blood flow from other areas of the brain, and so they survive. And a positive outcome means someone who is either independent or goes back to work. They may have a little bit of a deficit, but they can function independently, and that's what a good outcome is. And so up until the last few years, this has been the mainstay of the expectations for a patient who has a stroke and what they can expect to have as an outcome. So where do we go from here? So one of the issues about stroke is this timing issue, right? So to get to a hospital within 4.5 hours is challenging. You could have been seen right now having a stroke, but if you live in Sudbury, good luck getting downtown Toronto or to Trillium in 4.5 hours, right? Even with the helicopters and things like that. So where you live has a huge determinant on your ability to be treated. We have a network of neurologists and hospitals. So if you go to an outside hospital, you can call a neurologist who will assess you via video and can give you this medication if you arrive in that 4.5-hour window. But other than that, you're not going to get treatment. And any new treatment, many of these physicians in these hospitals don't know about it. So one of the things I do is actually go out to these community hospitals to let them know, if you have a patient with a stroke that comes 6 hours, 12 hours out, call us, because there's something we can do. So in this particular region, you may not know, but there are only really 130 hospitals in Ontario, 10 of which have neurosurgery services. Only 7 have neurointerventional services, right? Trillium being one of them. So if you have a problem, you're going to actually come to Trillium for your treatment. And that's for people living in Brampton, Mississauga, Oakville, Milton, Etobicoke. All of these people go to Trillium as their neurosurgical center. So over the last 30 years, there's been a lot of different things that people have tried to treat stroke patients, right? And TPA has probably been the best thing that we've found, but again, it doesn't treat everybody. Sorry? Yeah.
Before we leave the topic.
Yeah.
In your patient's case, right?
Yeah.
You don't know when it actually happened.
Yeah. No.
Now, if they knew it happened at 6 o'clock, you would have treated them. Would that be?
If they had arrived within 4.5 hours of last seen normal, they would have gotten the TPA medication.
Now, what if you assume that it came within 4 because nobody knew when it really happened? Would that medication be still work?
No, you can't assume. So it's based on the history. The last seen normal was 11 p.m., right? So that's when the physicians will do it. It's based on the literature. It's based on medical legal. If he has a hemorrhage and dies, you're liable because he's 8 hours out as far as anyone's concerned. Yeah, exactly. Yeah. Sorry? If he bleeds, yeah. Yeah. So the idea is that when you have the stroke and you're more than 4.5 hours out, the blood vessels themselves have died. And when you give a clot-busting medication, that clot-busting medication will dissolve the clot, blood will be restored, and that blood will hemorrhage into the brain. And so the trials have showed that 4.5 hours out, you're more likely to die of a bleed than you are to survive your stroke. So in that, the trials that we've done, this medication was great. We've also tried medications to preserve the brain to prevent it from dying. Those didn't work. We've also tried devices where you can go up into the pipes and just like you would unclog your pipe to try and pull out those clots or remove them. And those didn't work either. And what we found recently is that the reason they didn't work was a lot to do with the patients that were selected, how quickly you could do the procedure, the devices that you used, things like that. And so what ended up happening is we ended up using, we have this stent that we use. And so these are examples of actually some of the devices that were tried. They look a lot like things that you would, like spiders that you clean your drains with, right? So literally we put these in the brains and try to clean out the pipes and whatnot, but they didn't do very well. And so, ultimately you have to prove it at trial. So a few people might do well, but you need a large group of people to show that there's a benefit before it can be accepted as standard of care. So this is a stent, okay? It's called a solitaire stent made by Medtronic. So they were in the lab. Basically, this is a stent that we use for brain aneurysms. When a brain aneurysm is like a blister in the blood vessel, and we go in and we fill it with these coils, and sometimes those coils can fall out. So we put this stent in to keep the blood vessel open. And so I'll just show you an example of that. That's what this looks like. So that's what a brain aneurysm looks like. We put the stent in, and then we deploy the stent, and that's it. So one of the engineers at this company decided if you could go in to this clot and deploy the stent and open up the clot and the blood flow could go through, would that work? And so they tried it in these models, and it never worked. Every time they did it, it didn't work. So they would pull it out, try again, pull it out, try again. But every time they pulled it out, the clot would come with it. So they said, we have to find a new clot, new design for a clot, because this clot keeps coming out with it. And so somebody had a eureka moment and said, well, maybe we just put the stent up and drag it out, and maybe that will work. And sure enough, it does work. So this is an image of what it looks like. Basically, we identify the area that we think that the blood clot is in. We go through it with our little catheters with an X-ray machine. We deploy the stent, wait a few minutes, and then we literally drag the stent out. And for the most part, these clots come with them. So here's another story. So this is a lady, this is actually somebody I did a few weeks ago. So she's 44, otherwise healthy, non-smoker, no blood pressure issues, no diabetes issues. She's a 4.5-year-old child. She's not working, and she's out shopping with her friend. And she's recently had abdominal surgery for an appendix. So she's not on blood thinners or anything like that. And while she's shopping, she stops speaking. She can't get the words out, can't understand speech. Her strength is pretty normal, but she can't talk. And she's terrified, and so they call 911 and send her to an emergency department where they see that there's a large blood clot in the brain on the left side where she has her stroke. So because she's had, now we've seen her right away. She's come in an hour after her stroke. So she would be a candidate for TPA, but she's had surgery. So you can't have TPA if you've had surgery, right? So that excludes you. There's a lot of exclusion criteria, and that's one of them, because the idea would be that you would bleed out into the abdomen or the other areas where you have that. So 10 years ago, she would be left disabled from this, right? And instead, because she can't get TPA, they called us, and we transferred her to Trillium. And so what we did is we quickly went up with our catheters. We deployed the stent into the clot, and I'll just show you her images. So if you see right here, this is basically, we're looking at her head on. This is the large artery that feeds blood to the brain. This is what it should normally look like. And here we're missing a lot of blood flow in that area. And so what we know is that we should expect the blood flow. We follow it all the way back, and right here is where there's no blood going. So the clot must be there, right? If there's blood flow, that's where the clot should be. So what we do is we go through that, we deploy the stent, and we drag it out. And within about 12 minutes, we can restore blood flow on this right side here. That's all restored, and immediately, as she's on the table, we do this while she's awake, she starts talking. She starts moving, and she's completely back to normal. It happens that quickly, okay? And so the big question is this is a remarkable thing, and this is what the clot looks like when we drag it out. So it's a tiny little thing. It's not that big, but this could have ended her life, could have ruined her family's life, and create a significant amount of disability from something this small. So the real question is, well, we know we can treat people within 4.5 hours. Can we do it beyond that, right? So the idea is the same. If somebody's had a stroke longer than 4.5 hours, we remove the clot, we restore blood flow. That blood flow may, start to bleed out into that area of brain. So initially, about 2 years ago, we were only treating people to 4.5 hours. Then we did a trial, and then we got to 6 hours. Okay, now if you have a stroke out of 6 hours, you can have this treatment done. You can't get TPA, but you can have this treatment done. Then a big trial out of Calgary looked at 12 hours and found that even at 12 hours, people do well, right? And so recently, almost a few months ago, a trial looked 24 hours out. You still will do really, really well. So the wake-up strokes now. So that patient who had a stroke when he woke up, it doesn't matter. We would have brought him in, we would have removed his clot, and his outcome would have been significantly different from what it was. So this is just a summary of those trials. So if you compare the left, which is just medical management, so the red area is 50% who are disabled and 30% who have a good outcome. If you look at the right side, 50% actually have a good outcome. So 50% of people return to work, return to complete independence. This lady went home 2 days after this procedure, right? Totally fine. And then only 37% are left disabled, and that's because when you do someone out to 16 hours, they may have completed their stroke. Whether you return blood flow or not, those brain cells are dead, right? And so the challenge is to select the patients that are going to do well and not those ones that will not do well. And even the death rate has cut in half. So this is kind of a game changer for medicine, and very few times in medicine do you find something that's so effective at treating disease, especially a disease that's so prevalent in the community and so devastating. Yeah.
What is to say that this is not going to happen to her again?
So what typically happens after someone has a stroke, the initial management is to save their life or take the clot out. Once that's done, then they have an extensive workup of why they had the clot. So the two major things, we look at all the blood vessels to see if there's narrowing of the arteries. We can either do an operation or a stent to open that up. Or we look at the heart. Is there an arrhythmia or a problem with the heart? We look at the blood. Is there something that causes the blood to clot? Do they need to be on blood thinner? So they have that entire workup done, and that's it, to prevent it from happening again. Right? So there's a lot of things we do afterwards to prevent it, and that's always been the case. Even with the TPA era, we were always doing that, preventing the second stroke. If you can survive the first, we can do really good things to prevent you from having another one. So the take-home message really, you still don't want to be on our table, right? 80% of strokes can be prevented, right, with just simple changes to lifestyle. So weight loss, smoking cessation, alcohol reduction, exercise, diet, and then medical management, right? Blood pressure management is key here, right? That's the #1 cause for hemorrhagic stroke, for ischemic stroke, cholesterol, diabetes, and blood thinners if you need them. And then after prevention, then we talk about recognizing stroke. So that FAST algorithm, right? Facial twitching, speech and arm weakness. Those are the things to recognize, calling an ambulance. And then finally, to understand the treatment modalities. Because believe it or not, you may be more educated than your physician about stroke now, right? So if you come in at 12 hours and they say, oh, you can't have TPA, they're like, well, what about an embolectomy? What about taking the clot out? Oh, well, we don't do that here. Well, I want you to call. We have a service in Ontario where you can call us emergently, and we will transfer you in the middle of the night to do this procedure. And that is available to anybody in Ontario. So sometimes you have to advocate for yourself in these scenarios. And so a little bit about Trillium. So there's 4 of us who are interventionalists. The majority of what we do are, aneurysms, but on call we do these stroke procedures. This is in addition to our neurosurgical practice. So I'm the head of that division right now. And so that's growing, and we're expanding it, and we're trying to upgrade the technology that we use, which is this big X-ray machine, to look at the brain and to look at our catheters and things like that. As the catheters get more and more advanced, our technology has to try and keep up. And right now, we're a little bit outdated. And so I was the chair of the Diwali Gala last year, and we raised over $600,000 for this new machine, and we're planning to purchase that machine by the end of the year. Costs almost about $3 million. And again, this year I'll be chairing the gala with my wife, Sonia, and we're hoping to raise money for that as well. So I'm just going to do a quick plug-in for the Diwali Gala. So it's October 26th this year, and you can buy tickets to join us and support the cause, and this is exactly what it's going to go to. So whatever community you live in, realize that Trillium is your neurosurgical center, and the better technology we have, the better we can care for you and your family.
For people who live on the other side of town, which is the neurological center?
You mean Toronto?
Say downtown Toronto or...
Yeah, so the centers are, so downtown we have 3, Sunnybrook, St. Mike's, and the Toronto Western. Right, these are the 3 centers there. Trillium is the center for all of the West GTA. There's Hamilton, London, these are the other centers. Outside of that, you have Ottawa, which is the only other center. So we take people from Barrie, from Collingwood. I've had patients from Sudbury come. But we all have a region that we cover. So even Toronto Western has a specific region of North York that it covers. Patients in Richmond Hill will go to Sunnybrook, and that's kind of how things are covered.
Preventive medical care.
Yeah.
Last one was that blood thinner.
Yeah.
Should a normal healthy person also go for the blood thinner, or it has to?
So it's a good question. Blood thinners really pertain to people with the arrhythmias of the heart, right? One of the major causes, the 40% patients have embolic strokes. So when your heart flutters a little bit, what happens is the blood doesn't flow. And when blood doesn't flow properly or it stagnates, it clots. And when it clots, it forms these clots that can go up into the brain. So the idea of being on blood thinners like warfarin and things like that will thin the blood, prevent those clots from forming. Those are the major prevention. Being on aspirin or Plavix, those types of antiplatelet blood thinners are helpful for people who have narrowing of the arteries. People over the age of 50, aspirin doesn't really hurt. There's a lot of cardiac benefits and benefits to stroke, but you'll have to talk individually about what your risk factors are.
Is it the family physician indiscriminately tell the patient to take 81 milligram of aspirin?
Yeah.
And it has resulted in some cases causing the hemorrhage.
So aspirin really is good for you, right? More than anything, all the different reasons, cardiac, stroke, even if you're a healthy guy, daily aspirin will do things well. You're on an airplane, blood clots in the legs, things like that. It's not a potent blood thinner. It's not something that will cause a hemorrhage. It's not something that will really worsen a hemorrhage. In fact, we will operate on people in the brain when they're on aspirin. Other blood thinners like Plavix and warfarin and apixaban, those are things that are very potent, and so you really have to pick and choose whether you need to be on those.
And as a neurosurgeon, do you think we'll ever reach a stage when we'll be able to see brain cross blood?
It's an interesting question. In fact, it sounds ridiculous, but there's a guy in Italy who's looking to do a head transplant, right? And so, a head transplant. So the idea being, if somebody were to be fully paralyzed, right, you could put them or transplant them onto an able body. Sounds ridiculous, but the only limitation to that is reconnecting the spinal cord. We can reconnect the carotid arteries, we can reconnect the bones, we can reconnect the tissues, the trachea, the esophagus, all of the organs in the neck we can reconnect, but if you can find a way for that spinal cord injury to recover, you could do a head transplant, so yes.
So my question is simply, a blood clot anywhere in the body can cause a stroke. Doesn't have to be near the brain or near the weight.
No, so not anywhere in the body because you have a natural filter, which is the lungs, right? So if you have a blood clot in your lungs, in your legs, it will go to your lungs first and cause what's called a pulmonary embolism, so a clot in the lungs, which can kill you. So that's itself very dangerous. Few people have a hole in their heart called a PFO, right? Patent foramen ovale. It's a congenital thing. That can bypass the lungs. So if you have a clot in your legs, it can bypass the lungs, go through that hole in the heart, and go into the brain. So there is a scenario where that can happen, but mostly clots will have to happen from the left chamber of the heart, which is where after it's gone through the lungs, which is the filter, then there, if a clot forms, it'll go into the brain. So anywhere from there upwards, that will go, but not everywhere in the body, no.
Doctor, recently I saw a study that says unless you really have a heart problem, the doctor is that aspirin is not good for you, and it's only 2 months ago, so big study.
Yeah, I mean,
and aspirin was not as allegedly that it's very good for you.
Yeah, so I'm not familiar with that. Obviously, I don't see patients in that regard as risk factor management, so they're seen by stroke neurologists. But there is controversy in that a lot of patients are recommended, even by family doctors, to be on aspirin for many different reasons. The main issue is what is the drawback to it, right? So certain studies will look at a cohort of population that are high risk for certain things and say, are they at risk of bleeding in their joints, bruises, things like that. So it's a balance. I think it's a selection of patients. There's certainly a group of people who will benefit beyond those who just have heart disease or stroke. And there's some people who may not benefit, who have higher risk. Those are probably people that have surgeries and are more prone to falls and things like that. So I think there's a selection there. Not everyone should be on it, but it's probably more beneficial than not, even for our sakes. Immediately, you know, if somebody has a stroke, we tell patients to chew an aspirin and go to Emerge, right? It helps, and everything that we do in the angio suite, the stents, everything, we put people on aspirin.
First of all, I would like to request all who are attending, they should give a good round of applause for what you are doing and what you are doing. And my second question, doctor, is brain transplant, will it be possible anytime in the future?
So in my lifetime, probably not, right? As I said, the limitation would be the repairing the spinal cord injury, right? Now, there's a lot of work on that for spinal cord injury. The main promising field is stem cell transplant. So when I was supposed to go to Stanford, one of the things I was working on was a trial where we were doing stem cell transplant for people with chronic stroke, 2 years out of their stroke, and people with spinal cord injury, and people with trauma. So 3 different populations of patients. And you would basically take the stem cell slurry, put it into the brain, and hope for some recovery. Now, there is promise to that. It does work a little bit in that you can regrow neurons. The issue is regrowing pathways, right? So, for example, in the spinal cord, these are if you think of it's a wire, it will regenerate, but it might not have the right pathways that will regain movement. So having those things actually be functionally effective rather than just regrowing brain tissue is the challenge. Now, you know, you wouldn't have foreseen iPhones 10 years ago, so who knows, or 20 years ago or whatnot, right? So who knows what's going to happen?
I have 2 things. One is my younger brother back home, he got a stroke, and within an hour he was hospitalized and surgery was done. Today, thank God, he is totally normal. But what you said that investigations would be done that why that stroke has taken place. What kind of investigations are to be done?
So, I mean, it depends a lot on what the stroke was. Sometimes people tell you there's a stroke, but it's actually a bleed or a hemorrhage, right? We typically will never operate on someone who has an ischemic stroke. So if you had a bleed, the mechanism for that is a lot different. Initially, there's a gamut of tests that are done. Obviously, blood work, looking for reasons why you may have clotting of the blood, looking at your heart, so a thing called a Holter monitor that looks for the rhythm, an echo that looks to see what the structure of the heart is. We do CTs of the neck and ultrasounds of the neck to look at the arteries. These are the common things. So we send out kind of a net to look out causes for that. And then the funny thing is ultimately people are put on relatively the same medications. And sometimes we see these same patients back. And one of the procedures I do is I actually open up the carotid artery with a stent as well. Or I do an operation to open it up. So that's a possibility.
Is there any role for the laser treatment like?
So lasers are just kind of a gimmick that is done by the Americans, and a lot of urologists use it to dissolve things, but in brain surgery, there's really no lasers that we use. There is a laser that is used to clot blood vessels that's used sometimes. That is no better than anything we're using currently. And then the Laser Spine Institute, really, they do the exact same operation that we do, but rather than cut out a disc, they just burn it with a laser. So it's more just to get people to come to them when you're, making money from your services, but there's really no role for lasers right now, at least, for treatment.
One of the questions, maybe your comments. How long did that operation on that woman, that 40-year-old woman, take to remove that clot?
So it's 12 minutes. So we have actually criteria based on the trial. So one of the reasons that a lot of the previous devices didn't work is it took too long. You need to revascularize someone within 60 minutes. So we have what's called a door to puncture time. So when they arrive at our hospital, have their CT scan, they need to be on our table and have a groin puncture within 60 minutes. And we usually revascularize within 30 minutes. So 90 minutes from the time that you come to the emergency department before blood flow is restored to the brain is what we are trying to achieve. It's challenging because you can go an entire week and there's no strokes, and you live here, you have to come through traffic. You know, the ambulance has a siren to come to the hospital, but I don't, right? I have to wait in traffic to get there. So the patient has to wait until I get there, and then we do the procedure. So we do have these criteria. Outside of 90 minutes, there's a dramatic decrease in the outcome or the effectiveness.
37 years ago, my dad died of brain aneurysm. We still don't understand. Is an aneurysm the last possible event stroke afterwards? Because we're trying to understand.
No, so a brain aneurysm is kind of totally separate, right? A brain aneurysm is in the stroke umbrella. It causes what's called a subarachnoid hemorrhage. So if you think of the blood vessels as these kind of pipes that feed blood into the brain, at the major junctions where they fork off, you can get these blisters, which is damage to the blood vessel. That blister is vulnerable. It can burst and bleed, right? These blisters are located in the subarachnoid space. So the only thing that bleeds in that space is aneurysms, and they bleed under high pressure, right? So they rupture and they bleed. 30% of people die immediately from a rupture. They never make it to hospital, right? If they do make it to hospital, 50% have a bad outcome. They either die or are disabled, and 50% will be normal. The first thing that goes wrong is they can re-rupture. So when people come in, what we do is we protect the aneurysm, or we either clip it or we fill it with coils. If you're lucky enough to discover that you have an aneurysm before it ruptures, then we treat them. So, you know, every 2 weeks on a Wednesday, I treat unruptured aneurysms to prevent them from rupturing. Yeah, I'm sorry to hear that.
Thank you, Doctor, for making such a complicated subject so simple for us. My question is about first aid. What first aid you and the family members could give it to a person? And secondly, there's been not on social media that you should keep a pin. And the moment somebody gets a stroke, break his all the time fingers and starts flowing. Does it help?
No. You probably need the blood. So yeah, if it's a stroke specifically, so first aid really is, the focus of first aid is to continue perfusing blood to the brain. Everything you do in first aid is meant to do that, and then the focus of that is when the heart stops, so the pump, right? And so all you're really doing is you're pumping the blood by yourself instead of the heart, and you want blood flow to the brain to preserve the brain, right? That's the goal of first aid. In a stroke, no amount of CPR or anything is going to help. The heart is beating, blood flow is not going, right? The only thing you can probably do is get them to chew an aspirin, right? And then bring them to the emergency department as soon as possible. The caveat there is that 10% of strokes are actually bleeds. That aspirin could make it worse. There's some argument of whether to give it or not, but overall, if there's a 9 out of 10 chance that it's an ischemic stroke, and they'll do better if you give them the aspirin. That's really all you can do. The faster you get them to treatment, the better. Hereditary? Yeah, so there is family history is a predisposition to that for a lot of different reasons. Some people have family genes where you have high cholesterol. Others have vascular anomalies that make it more predominant. Heart conditions, things like that. So certainly there's a family component. If you have a family history, you're more likely to have a stroke. But specifically, family history of stroke, no, there's no genetics related to that.
The point of aspirins, I don't think people are very unclear about your message about the aspirins.
Mm-hmm.
That I still think that aspirin should be taken by people who are over 60, or 50, depending upon the risk factors, of course. But an aspirin a day, as you said, it doesn't cost much, 81 milligrams. And we take it, it does, for some reason, at least we feel that it makes a difference.
Yeah.
Second point, what is your stroke rate in stenting as opposed to open carotid artery and artery? I know it's a medical question, but
Yeah, so I agree with you when it comes to the aspirin. It makes you feel better. Whether you're doing anything or not, who knows? When it comes to, so what he's talking about is the carotid artery. So the artery that feeds the brain, it splits right here in the neck. And where it splits, it causes high turbulent flow. And it's a very common area for plaques to form. So if you have high cholesterol, high blood pressure, you'll form these plaques, and it will narrow the artery significantly. And people can have narrowing up to 90%, and it reduces blood flow in that area. Sometimes you can break off a piece of that plaque, and it goes up into the brain and causes a stroke. So we have two treatment modalities that we can do. Traditionally, we would do an operation where we actually cut down onto the artery, split it open, peel off the plaque, and then resuture the artery closed. Now, during that procedure, you have to clamp off the artery, and you have to do it quickly. You have to do it within 30 minutes or the person has a stroke. So I've done that operation, and for me, it's stressful, right? You have a timer on, you have somebody's artery that's clamped and whatnot. Yeah, whereas, and so in my hands, I can do the stenting, where we go up with a catheter, we put a little mesh in. If the plaque breaks off, the mesh grabs it, and then we put in the stent and it opens it up, stents it open. So it doesn't peel it off, but it just opens up the blood vessel. So there is some, depending on where you go, vascular surgeons and neurosurgeons who are more comfortable with the artery and don't do stenting will offer you the surgery. And interventionists like myself who do both may offer you the stenting. The literature shows that it's actually equivalent. The outcome is relatively the same. They're both good. The difference is, if you have the stent, you're more likely to have a stroke during the procedure. And if you have the operation, you're more likely to have a heart attack during the procedure. So patients would rather have a heart attack than have a stroke. So they choose the surgery. Yeah.
I don't agree with you.
That's a good choice. What if you actually have hereditary of some sort, narrowing of the arteries? Can you put this in?
Yeah, there's really... Yeah, so in Moya Moya, we wouldn't do that. That's a rare condition. So that's a different form of ischemia, right? But no, we can't open up blood vessels. There was actually a trial that looked at intracranial narrowing of the blood vessels in the brain, and putting in stents to open those up, and people actually do worse because you actually block off the small little blood vessels that go into the important areas of the brain, the perforators, and so people actually do worse. So we don't do that. We don't do it for Moya Moya. Sometimes people have very tortuous blood vessels, so tortuous that we can't even get our catheters through. It's just too difficult. And in those scenarios, sometimes we have to abort. We actually stop. There's no surgery that we can do. In Japan, there's one guy who's doing an operation where he goes down, opens the blood vessel, and takes out the clot, but no one does that here.
I have two questions right here.
Yeah, hi.
Hi. So the first one is, were these mostly lacunar stroke patients, and do you do surgeries on hemorrhagic patients?
So no, they're not lacunar strokes. So lacunar strokes are these small blood vessels, what we call perforators. So you have large blood vessels, and then off of those come these tiny, tiny blood vessels, like millimeters in thickness. And those blood vessels are important in feeding really, really important structures of the brain. So you don't have to have this massive stroke to be disabled. But if you have, for example, a stroke in the thalamus, you will be just as disabled as a massive stroke, even though it's small. So the lacunar strokes tend to happen for people who have high blood pressure and high cholesterol. There's really nothing we can do for that. So when we do an assessment, so if somebody comes in with a stroke, they have a CT angiogram. We look at the blood vessels. If they don't have a large vessel occlusion, meaning the major blood vessels in the brain are not occluded, there's nothing we can do. In some cases, people are given TPA. In other cases, we give aspirin and Plavix, and that's really all you can do. In terms of hemorrhages, there's really no scenario where we do operations for bleeds related to strokes. Most people, the most common kind of bleeding in the brain is in the deep areas of the brain, the thalamus, things like that, and that's due to high blood pressure. And the studies have shown that there's no benefit to surgery. There's a small scenario of patients who have large hemorrhages kind of on the outside of the brain who sometimes can benefit, but they're carefully selected. And then sometimes people have a bleed and you think it's a stroke, but it's actually because of an aneurysm or it's because of an AVM or things like that. And those are usually in people under the age of 40. So we will do tests to make sure that there's nothing underlying or even a tumor or something like that. But lacunar strokes, basal ganglia hemorrhages, we don't treat.
And the second question is for your you were the person so the stem cell transplants were these on 2-year-old patients post-stroke, and these were on what, like patients with motor strokes, motor impairments, or did you look into cognitive impairments for these patients?
So I didn't go to Stanford, I didn't do the trial, but yes, the study was looking at patients with large territory, usually MCA territory strokes, who were 2 years out and had not had a significant recovery. And the idea, the reason for that is you don't want someone to artificially recover, right? In that the first year you will recover neurons and you'll compensate and all that stuff. So you want someone to plateau. There is no room for recovery for this person. So any improvement is related to the stem cell transplant. And so those are the patients that were selected. Small strokes were excluded as well.
How do you define
Take the microphone, please.
how do you define a neurosurgeon from an ivory tower?
Yeah, I'm not sure what that term is. I think that means academic. I'm not sure what I didn't write that. Yeah. Yeah, no, well, I mean, I didn't write that, but I think what that means is somebody at an academic center. So that means someone who does a lot of research and is not hands-on. And so you may see their resident or their fellow, but they don't actually are the ones that are doing the operations.
And what is the majority if you look at statistics in market?
Well, a majority of neurosurgeons are academic, right? There's very few that are practicing in places. What's that?
That poses a threat.
No, I mean, I was trained at an academic center, right? I wouldn't have had the skill set if it wasn't for those ivory tower neurosurgeons. But that's a term, it's, you know, I mean, I don't know if it's derogatory, but there's a lot of good neurosurgeons that also do academic work. Yeah.
Any other questions, guys?
One last question. Those who are taking blood thinner, and in the event when they have fever or something, they are advised that not to take blood thinner if you have taken an Advil 6 hours earlier or 6 hours after you should take. Otherwise, blood thinner will be not good to have if you have taken an Advil.
That's very specific to family. That's out of my area of expertise. Yeah. You'll have to ask. Yeah, that's just.
Doc, I have a question.
Yeah.
Personally, I got a couple of stents. And I've been on a Plavix every day. Does that prevent any strokes? Or is it, as can stimulate a stroke?
So it's good to have, right? So in someone who has narrowing of the arteries, right? The initial management is medical management. So if you have 50 to 60% narrowing of the artery, we don't even treat that. We put you on aspirin and Plavix. So if you have had stents, let's say in the heart, and that's what we call coronary artery disease, you're likely to have narrowing in other blood vessels, right? It's not that just focal in the heart, it's usually everywhere else as well. So you will probably be protected from having a stroke by being on those blood thinners, right? But having said that, you still have to have the risk factor workup to see maybe your narrowing is more than 90%, and in that scenario, blood thinners may not be helpful and you still need a procedure.
How to keep brain young?
What's that?
How to keep brain young?
Use it, right? Read.
So I think I'm fine and healthy. So you think I need to go in for a diagnosis to just see, just in case I'm in shit or something like that?
Well, I mean, a yearly checkup, right? As part of that yearly checkup. Sure, I mean, they'll look at your risk factors and there's screening tests and things like that. Yeah, so if that's the case, then yeah, they would send you for an echo or an ECG or things like that and then work that up for sure. Who? Women or men you're talking about?
Who is more prone to get stroke?
So those people that have those risk factors, right? People who have high blood pressure, diabetes, yeah. Yeah, there's lots of different risk factors. So basically stay healthy, eat healthy, and you'll avoid.
In many cases, the loss of speech and loss of hand movement is reversible. Is it always the case, or?
Yeah, so that's getting kind of into the nitty-gritty of stroke and stuff. And so what we found with TPA, and these are the trials that were done with TPA, if you come in with pure aphasia, right, you're very likely to actually recover your symptoms without TPA. And so there's a lot of people, and you'll see even with the medical management, who actually recover from their stroke completely, never given TPA, never given any treatment whatsoever. TPA is a tissue plasminogen activator. So what it does is it dissolves clots, right? So blood thinners prevent you from, like antiplatelets, prevent clots from forming, right? The other blood thinners prevent the pathways from forming, but this one actually dissolves a clot.
Does it improve the brain function?
TPA? Not that I know of, no. Yeah.
So when you go for the yearly checkup and they look at your risk factors and you don't fall within those risk factors, they don't send you further examination. Is it worth it to go to a Cleveland Clinic or any of these private who go further for you and you pay for it?
Yeah, that's kind of an ethical dilemma. You know, we don't really know what the right answer is. What I can tell you is that the more you look, the more likely someone's going to do something to you, right? And so people who have full body MRIs, you know, yeah, you're going to have unnecessary operations and things like that. Exactly, yeah. So sometimes it's worth not knowing. But at the same time, we do screen people with, you know, if you have 2 family members with aneurysms, for example, we will screen you.
Any more questions, guys? Well, let's give a big hand. Very informative session, I'm sure all of you agree.
Yes.
I hope we can have more of this kind of
I
sessions.
just wondered if we can get some elements of your speaking notes and put it on our website.
Sure, I can send you
We're
my
going to
slides.
share the.
Yeah, electronically, we put it on our website,
We can do
so,
that.
because a lot of things that was said today, but the memory being what it is, you'll only remember till another half an hour, right?
Guys, you have also noticed the Diwali Day at Trillium, October 26th, but I also want to remind you of 2 other major events. One of them is the Canada-India Foundation Higher Education Forum, which we are having on July the 5th, and the Canada-India Foundation Award Gala on July the 6th. Please keep these dates open, keep your wallets open, and make sure you write the checks to the tables. More importantly, there's also August 8th, which we are having a gala. This Sunday, we all know that we had a tragedy in Toronto very recently, day before yesterday, where a driver took care of 10 people's death and 2 other injured. We are having a condolence meeting, Canada India Foundation, at the Vishnu Mandir Temple at the Peace
Park.
The Peace
Next
Park.
to the monument for the fallen soldiers and Mahatma Gandhi statue. This is a condolence meeting, and the Premier of Ontario and possibly the Mayor of Toronto will be in attendance. The program will start at about 11:30, but the main, I think, is at 12. So if all of you are able to come there, at Yonge and Highway 7, the Vishnu Mandir premises, next to the monument to the fallen soldiers and Mahatma Gandhi statue. So please do come. Thank you.
Here goes my golf game. Okay, gentlemen, ladies and gentlemen, thank you very, very much.